We came from it from a number of different angles, and I think the most important angle that we should come from is what would our patients want in terms of our standards. And we have a really nice framework for that anyway, which is the whole, I want it to be safe, I want it to be effective, and I want a really good experience while that's happening. So that in itself is the kind of basis for how any healthcare standard should be written. But we did have a conversation about exactly what is a healthcare standard, because actually there are multiple standards at multiple levels issued by multiple people, and that in itself is one of the problems. The other issue is that because we have multiple standards, protocols, guidelines, audits, research, numerous things that tell us how things should be done, and actually, if we just stopped today and started to implement all of those things, we might get a long way. And so one of the big issues about healthcare standards is not just about who should set them, but how should they be implemented and how effectively can they be implemented, and what help is required to do that. We also debated the difference between healthcare standards and clinical standards and the kind of judgment standards that need to be made, as opposed to standard operating procedures, which we accept are applicable in some of healthcare, but not all of healthcare. And they, in themselves, can be implemented, if possible, in a sort of 100% reliable way. But that's a very, very different picture from a lot of the care that we provide.
So, in a nutshell, there's probably too many standards. It's a little bit.
I think, if I was to sum it up, there are too many standards issued by too many different people, talking about probably very similar things in different ways, and that actually what we need to do is not just concentrate on the standards themselves, but on the implementation of those standards.
How do you go about simplifying it then? Who gives up their standards?
Well, can somebody explain where NICE standards is that the answering feature? Will Royal Colleges feed into NICE? Will all the research evidence feed into NICE? Will we start and get one source for standards?
Okay, so under the new procedure, we need some clarification how it's going to work.
I suppose my comment is that there might be too many standards, but there are people making them. So the answer is there are too many organisations rather than too many standards.
Okay.
Cut down on the number of regulators and so on, we might get fewer standards. Really.
I think that the table said that in a slightly different way, that there are too many people asking for slightly different, similar things, but not in exactly the same way.
It's not that there are too many standards, there are too many different bloody people asking for it.
Anthony Samora just got it exactly right, too many bodies, but what you need to do is go back to the patient and the interface between the patient and the clinicians delivering the care to define the standards that really matter. It's my impression, having listened to Robert Francis's inquiry, I've been there a few days, but I've looked at a lot of the evidence, that standards have tended over the last decade to descend from Whitehall, and we've got lots of initiatives with Q in the title, and we need now to really audit all of those back to what does a patient really need when he or she is with the clinician. Start with that data set of what should be delivered, measure it, move it upwards through the system to provide assurance, rather than trying to see regulation inspection as somehow descending from the heights, because it'll never capture what's happening patient by patient.
Absolutely, and I suppose some of those things that matter to patients are about how they've been treated. It's the behavioural interactions that are quite difficult to codify in a set of tick box standards.
But before behavioural, it's surely you're there to be cured normally, and it's all the measurements, body functions, whatever, that clinicians measure first and foremost.
Yeah.
And those, as far as I'm aware, are not captured and turned into quality information for how a team is doing, how they've done with a ward full of patients. You get the individual stuff, and it kind of disappears.
So the organisations should be focusing on, are they doing those basic clinical measurements right?
Well, there needs to be a system for that, as Andrew's just disappearing, as in his industry. That's what's missing.
Fantastic.